Jason, please.
Jason Grebley from the Kirby Institute, UNSW Sydney. So my question's for Jag. Jag, we've got a critical sort of issue globally. So we've got these, effective therapies that are available, and we've got this massive bottleneck in terms of, the proportion diagnosed globally. And as Stuart was saying earlier, the issue is essentially the price of the tests. If the price of the test wasn't an issue, we could do HCV RNA screening in everyone. Now, and also even the companies that do have, point of care RNA tests, they're taking a bit slow to sort of move forward. Now, in terms of innovation, it's been really tricky to get diagnostic companies or even ones that are starting out to actually get the financing to drive forward and really innovate. We need shorter tests. Even an hour is not enough. They need to be shorter. So one of the, the issues, and I mentioned it this morning, but I'll harp on it again, is that, many times they're looking at the number of people globally that are infected with hepatitis C rather than looking at the numbers of people that we would need to test in order to then identify all of those individuals. So we almost need a reshaping of how we're thinking about it. So I'm just curious if you have any insights around what we can be doing as a sort of a global community, researchers, clinicians, to sort of make a better investment case, because I think there needs to be more investment into the diagnostics field to be able to sort of shift it forward, because global funders aren't putting the money into that. So I'd just be curious to hear your thoughts on that.
Thanks, Jason. Excellent comments. So let me start with, I think there are two issues we have to keep remember. One is the financing. Definitely that will not go away. But there is also another issue of reaching out to people. Like in the US, where screening cost is very low compared to the treatment cost, and screening is it never becomes a challenge when it comes to financing of screening. But still, we are not able to screen more than 9% of the population per year in the birth cohort. And if the US implements universal screening, it's very difficult to increase that screening rate. So it's not the cost in the US which is going to be the bottleneck. But in other countries, cost will become a bottleneck, and especially if the initial investment is needed. So I think it has to be, definitely we need cheaper diagnostics. Without that, it will not work. But that's not going to be enough. Even if we have cheaper diagnostics in many countries, reaching out to people would still be an issue. So the numbers, I think that as you mentioned, that the annual number of screening cases or diagnosis cases, those are sort of a guidepost. We are not saying that we should be doing this much. So this is more like if a program is being implemented, that provides a reference case. How are we doing? Are we able to reach that number or not? At some point, we'll have to cross that threshold. So that's the idea behind those numbers, the number needed to screen or diagnose in a given year. Does that answer your question? Sorry. That was there. That was this is to my capacity.
About it, because it's critical. We've got these drugs, and it's a matter of, how do we move things forward, and how do we make the case for greater investment in the testing side of things?
So I teach a course of how to handle a Q&A session, and one of the cardinal rules, never say, does it answer your question or not? You completely turn to the other side as soon as you answer.
Thank you.
So I have a comment and a question, and both are at this on the same vein. First, I agree that outreach screening is inefficient and expensive. While opportunistic screening may be less so. And I'll give you our example. So in the great state of Texas, there's a program or an entity called CPRIT, Cancer Prevention Research Institute of Texas. They have prevention grants. They give us a $3 million grant over 3 years. We did outreach. We screened 1,000 people through multiple settings. It cost us $1 million. We detected 9 infected people. 3 were lost, 6 were linked to care, 4 were treated. So the cost is $1 million per 4, excluding the medications. Then we did a simple fix at the county hospital. We implemented reflex testing. We got 300 people over 6 months. Finally, in the final year of the grant, we got that. So That's the comment. The question to you, Jag, is how do you model this? I mean, the screening test is cheap, but identification of people who are infected is quite expensive, as borne by our experience, actually, as borne by the entire conference. They're all talking how to find people. Take this, multiply by $500 a day. We already spent $100,000 today on screening. And I don't think that's factored in.
I agree that's right. So does your Q&A say it's allowed to say it's a difficult question? Or not, before I start answering? Yes, so the most studies, modeling studies, do not account for the cost of outreach and reaching out to different populations. One of the key assumptions we make is we have some underlying knowledge about where are we putting our dollars, like, or whatever currency we're using. So we need to know what is the underlying prevalence in a given pocket. We need to have some estimates. If we do not have those estimates, we may be looking at the wrong pocket. So and this is very heterogeneous. And Texas is one, but things can be different in Massachusetts. But and then this is very much true for countries like Pakistan or India, where it's very, very region specific. So it's not going to be one policy that's going to be implemented in the entire country, but it has to be very much specific to that region. So the cost of outreach or the cost of the screen, different algorithm, we have to account for that. And you're right that most studies that we've shown do not include those costs. So still, that the message then is that we need more financing than what we may anticipate in the end.
So just a comment related to both of these comments. So when we were trying to scale up screening in Pakistan, and we had discussion related to Cepheid and whether that will provide us enough throughput in our high volume clinics to be able to screen large number of patients and make them available for treatment decision making right away. And we realized that it is not providing that high throughput, and then amount of time that it takes to receive results is also very high. And that is where, when you look at core antigen, that may provide a better alternative in terms of high throughput. So that is where like the whole discussion around new diagnostic approaches comes in, especially for high burden countries. We need to think about that. Alnur?
Alnur Ramji from Vancouver. A comment and a question. I do agree that immigrant populations is part of this missing millions. We are doing an outreach project in Greater Vancouver involving the South Asian community, and it is outreach as well. It took about 6 months before everybody was on board. And then because you, as you correctly noted, you should really get the actual community involved. They said, we'll do a Hep C session. And guess how many people showed up to the Hep C session? 0. Because of the stigma. And I think if we are embedding any programs, the only time that actually people started getting screened is when it was about settlement, about education, about economics, about finding jobs. And still the outreach was challenging. And part of the issue has been when persons do come to Canada, they're not routinely screened. So we went to a public health clinic associated with an immigrant community or immigrant practice, and then they started screening, and the results are twice the number of screening in a matter of a month. So that's the comment. And the question really is, isn't it about time that we really should push towards the immigrant services screening when they're coming in? I know in BC, we've tried to really push on that, and it's been, well, we need, there's no defined context of that. And I think perhaps now is the time to get the defined context, not to stigmatize a disease, but as you very appropriately put it, as a package of overall health.
Thank you very much. And that's a complicated issue because the pre-landing screening is done by Immigration Canada. It usually happens pre-arrival. And the cost is borne by the individual. And I've had many discussions with Immigration Canada over the years that we should add screening on the pre-arrival screening. And the objective for pre-arrival screening is to decrease the burden on the healthcare system, and it's really for exclusion. And one of the other issues, so there's a potential for stigmatization there, but the other issue is that there's no linkage between what happens pre and post. And we have no system post to do any kind of screening. It's very ad hoc. And I can tell you that for TB screening, for example, where we do, I think, we really spend a lot of energy doing TB screening. The linkage for people, which a very small proportion who have TB prior to arrival get linked to public health post-arrival, and to be connected to TB services, that doesn't work very well. And so there's a huge infrastructure issue. So there's the issue in terms of we don't own that screening. It's Immigration Canada, and they don't really. That's a tough thing to change. And we don't really have any kind of connection between pre and post-arrival. And so I think that in the short term, I think that we have to ramp up post-arrival health promotion, and we have to get out to the into the clinical setting and maybe have reflex testing. I think that as you brought up, I think we should have these in our EMRs. We should be taking all of those tools. I think we do need to do some education with different communities, but it has to be done in a sensitive way. So it's complex because the system is not there to be able to do it easily.
Jordan?
Well, thanks both of you for great talks. And I guess I'll just make one comment to that, Eleanor, that we've struggled with this and shown that hepatitis B testing would certainly be cost effective for people coming from Asian countries. And the biggest resistance to that is actually among the Asian population, even when it's talked about as post-test, even post-arrival testing, because they're concerned that this will stigmatize immigration policies moving forward about accepting people from countries with a high burden. So I think it is a very difficult issue. My question is for Jag again, is just about the model. And when you think about these different testing algorithms, I'm curious whether you change at all the RNA prevalence among antibody positive people as time goes on. So as you treat lots of people and you get closer to elimination, the more people you test are going to be antibody positive and RNA negative. And I'm just curious if that actually works into the model. And if, in other words, if the testing strategy changes as you get closer to elimination.
So it depends upon the screening policy. If we're talking about one-time screening, that may not, I think to some extent, we can assume that it's going to remain constant if we're screening one sector at a time. And that's what we tested in the Pakistan population. But for high-risk population, that definitely, yes, we account for that, how the RNA prevalence changing in the antibody, if there's a repeated screening.
But it's also potentially more complex than that, because people, I mean, it's great if you can say we're going to test this little corner of the country and then we're going to move to that little part of the country. But the reality is you're going to roll out screening and people will probably be tested multiple times, no matter how you set up a screening program, because whatever interaction with the healthcare system, they're going to get tested if that's your paradigm. And I guess the thing that's going to change is that over time, as you treat more people, the number of people who are viremic is going to really drop. So the value of the antibody test becomes less and less useful. And in truth, the population may or may not be aware. Even if they know they've been treated, they may or may not know that they don't need to be tested or do need to be tested. And just something to think about with the modeling.
Thank you.
Thank you very much. We will move on to the next part of our sessions, which are oral presentations.